Alright guys, so we just went over the cardio conductive system, and I just want to remind you that there are plexuses that go to the heart, as well as the pulmonary, as well as the esophagus. And I want to remind you also that these plexuses carry both sympathetic and parasympathetic. So the vagus handles the parasympathetic, and the sympathetic trunk or sympathetic chain handles the sympathetic. One thing that you guys will learn is that the the nerves that innervate the cardiac plexus are also known as that are sympathetic are also known as accelerator nerves, and of course the parasympathetic are the ones to slow them down. So if you notice here, you have the superficial cardiac plexus, you have a deep cardiac plexus. It's going to handle both the pulmonary trunk and the heart, and it's both sympathetic and parasympathetic. So just remember that, okay? So you have vagus and you have sympathetic trunks for both, so remember that. Now, as far as the thymus, this sits in front of the heart. It is anterior to the heart. It is one of the few things that is in the anterior mediastinum. It's used for immune system. It matures T cells. You use it a lot as an infant to make sure that you can fight off infection because you have not been exposed to any infections. So as an infant, you're not very good at making antibodies, but you're a hell of a good at making T cells. So you make the T cells to help fight your infection off. In that sense, as we get older, we make more plasma cells and B cells, and we make more antibodies, and we have a great lymphatic system to help us out. So we make less and less T cells. So as you get older, your thymus depreciates and dies, and it diminishes so much you basically don't see it anymore by the time you're 60. So infants are immune compromised because they don't have a capability of making antibodies that well, whereas elderly are immune compromised because they don't have the capability of making T cells that well. So it's a vice versa thing. But if you notice, it's on the anterior portion. It is very large. As an infant, it covers almost the entire heart. But as an adult, it stays about this size until you hit your about 50s and it starts diminishing significantly. But it covers the aorta. Alright, now the anterior portion of the heart, we've already been over all this. Remember, the pulmonary trunk is anterior compared to the aorta. You have your superior and inferior vena cava. There's your azygous vein that's draining directly into the superior vena cava. On the anterior side, if you recall, the right ventricle is the majority, whereas the left ventricle is not. Here's your anterior interventricular artery behind this fat. That's your septum. It separates the left and the right ventricle. Okay? All right, now let's go over the lung position. Your right lung has 3 lobes. Your left lung has 2. The hilum is where all the artery and the bronchi sit. So the right lung itself has, lungs themselves, they have 2 pulmonary veins. Remember that? They're oxygenated. They're coming from the lung and they're going towards the heart, towards that left atrium. The right lung, you typically have 1 pulmonary artery for each. The right has 1, the left has 1. And then, of course, you have a primary bronchus for each in the lung. Okay, so the pulmonary arteries carry deoxygenated blood. The pulmonary veins carry oxygenated blood. That's something that the students completely forget when it comes to the lungs. There are also nerves and lymphatics that enter them just the same. So if you look at this, medially you'll have the bronchus. So anterior or superior medially you'll have the bronchi. Inferior you'll have the pulmonary veins, and then lateral you'll have the pulmonary arteries. So on the right lung, it's bronchi, pulmonary artery laterally, and pulmonary veins medially. Now look at the left lung. On the left lung, you have the pulmonary veins that are lateral, the bronchi medial, and the pulmonary artery is superior. So it's a little different from the right to the left. This is very, very important because when you see in the cadaver, it's important to notice where the pulmonary veins are. So the pulmonary vein on the left is superior, the pulmonary vein on the right, the pulmonary artery on the left is superior, the pulmonary artery on the right is lateral, and the pulmonary veins are both inferior, and the pulmonary bronchi is medial here, whereas superior medial on the right. Okay? Alright, let's go over the next portion. Now, if you look at the right lung, you have there's different fissures. You have a horizontal fissure here that separates the superior from the um, lower lobe and middle lobe, and you have an oblique fissure that separates the inferior lobe from the middle lobe. So you can kind of see them here. Here's the superior lobe, here's the middle lobe, here's the inferior lobe. The oblique fissure separates the superior from inferior, and the horizontal fissure separates the superior from the middle lobe. So there are three lobes nonetheless. The inferior lobe is more posterior than the rest of them. The superior and the middle lobe, you can see them more anterior. So if you're going to auscultate and you're trying to hear breath sounds, and you want to hear for the superior and middle lobe, you would hear in the front. If you want to listen for the inferior lobe, you listen in the back. This is why it's important for doctors to listen to both back and front. Now, let's talk about the indentations. This is the right lung, so you're going to see the esophagus posteriorly here, right? The azygous vein is also on the right side of the body, so you'll see that. There's an azygous indention there with the esophagus, so those indentions are there. Then, of course, the azygous vein leads to superior vena cava, so on the superior half of this indention, you'll see the superior vena cava. So the hilum is your reference point. If you're looking at it posteriorly, the esophagus is first, and then the esophagus. Anteriorly, you have the superior vena cava, and you have the inferior vena cava down here. Okay, so there are indentions for each, and you can see them here. So here's the superior vena cava notch. Here's the inferior vena cava notch. There's the esophagus notch, and then right under that, you actually have the esophagus. So this is just showing you where they lie. Okay, on the left lung, if you recall, pulmonary artery is superior, pulmonary veins are medial, and then of course you have your bronchus right there. So posteriorly, immediately you have your esophagus, just like posteriorly in the right lung you have your esophagus. You don't have the hemizygous and the accessory hemizygous are going to kind of be diminished here because you have this beautiful descending aorta that takes care of most of the space. So you'll have your descending aortic indention here. There's your arch, so you can see your arch here. And then of course you have your arteries. So if you recall, left subclavian, left common carotid, brachiocephalic, because you're going towards the lateral portion here. So it's left subclavian, left common carotid, and brachiocephalic. You see them here: left subclavian, left common carotid, and brachiocephalic. These are the indentions here. So descending aorta, aortic arch, brachiocephalic. Left subclavian, left common carotid, and brachiocephalic. And those are the major indentions you need to know here. The other biggest one is right here. Anterior to this, there's your heart. So there are your pulmonary veins, and there's your heart right there. So you have to remember where the heart lies as well. On the left, you do have a lingula. It means tongue. There is a small little indention, increases surface area of the lung, and it is there nonetheless. All right, now as far as the bronchial tree, let's go over these. You have your glottis and epiglottis up here. There's your trachea. You have primary bronchus, right and left. All right, this one for each lung. Since the right lung has three lobes, you have three secondary bronchi. They're also known as lobar bronchi. Since the left lung has two lobes, you have two lobar bronchi, two secondary bronchi. Okay? Now, in each lobe, there are beautiful segments. There's up to 36 segments in each one. So those are called tertiary bronchi. They're also called segmental bronchi. So primary bronchus, main bronchus, secondary bronchus are also lobar bronchi, two on the left, three on the right. And then off the lobar bronchi, you have segmentary bronchi, and there are a bunch of segments. I'm not going to go over them, but that's the brachial tree. Okay. After the bronchi, you hit terminal bronchioles, and then respiratory bronchioles, and then alveoli. So that's the chain. It's trachea, primary bronchus, secondary bronchus, also known as lobar bronchi, tertiary bronchus, also known as segmental bronchi, and then the terminal bronchiole, the respiratory bronchiole, and the alveolus. The difference between the bronchiole and the bronchi, if you notice, the bronchi get smaller and smaller and smaller as you hit the segments. Well, the bronchioles get smaller and smaller, and they do gas exchange as well as the alveoli, especially respiratory bronchiole. So these are all the segments. If you notice, there's a crap load, right? So I'm not going to make you memorize all of them. What I do want you to understand is there are 10 segments in each lung. So they differ. If you notice that they labeled here by S1, S2, all the way to S10, they differ. The biggest important thing here is that when people have lung cancer and so forth, we can remove segments without having to compromise the rest of the lung. Because if that segment is compromised because of lung cancer, we can remove that particular segment or that particular lobe, and the rest of the lung can pretty much function on its own. The lung is regenerative, so each segment has a regenerative property. So just keep that in mind, okay? So anyhow, you do not have to memorize all these segments. You just have to understand the big picture here, and that there are segmental lobes or segments in each lobe that are equally important. All right, now as far as pulmonary vessels, the bronchial arteries that come off that off the aorta, they supply oxygenated blood to the non-respiratory elastic tissue of the lung. All right, what I mean by that, it is not going to the alveoli. It is feeding the lung tissue, not the airways. Okay, so the single right bronchial, it's feeding the lung tissue and the bronchi, which is not the alveoli, not the part that's actually diffusing oxygen. The single right bronchial artery arises from the third posterior intercostal artery, and it originates in that sense. The two left bronchial arteries arise directly from the anterior surface of the thoracic aorta, and of course, the superior left bronchial artery arises from the vertebral T5. And the bronchial veins drain into the azygous vein on the right and the hemizygous vein on the left. This is the most important part. Out of all this slide, you need to understand there's one right bronchial artery, two left bronchial arteries, and the azygous vein drains on the right, the hemizygous drains on the left into from the bronchial veins. Okay? Again, these are not pulmonary. Pulmonary arteries is only one, but you notice after the pulmonary artery, it splits. There's two on the right, one on the right and two on the left. So please remember that, okay? All right, the pulmonary innervation. The vagus does parasympathetic. It'll constrict the bronchioles and constrict the trachea and bronchi, whereas the sympathetic will dilate the bronchioles and dilate the trachea and bronchi. So fight or flight, you need oxygen. They'll dilate the system. Rest and digest, you do not need that much oxygen. It will constrict the system, okay? This holds play is that if you have a very, very delicate sympathetic system and you have asthma, it can really cause issues. All right, so remember that. Pleural effusion. When you get fluid in your lungs, it could be due to your heart. So if you have your left side of the heart is compromised because the anterior interventricular artery is clogged, then you can get pulmonary edema, and that leads to pleural effusion. You build up fluid from the bottom up like a swimming pool, and you start suffocating in your own fluid. The only way, so you're accumulating fluid within the pleural space, and the lung is compromised. It can happen between the serous, like here on the left, it can happen between the pleural membrane and the visceral membrane. And of course, we'd have to do a thoracocentesis where we actually get the fluid out with a tube. Or worse off, with the heart, if you build a fluid and it backs up into the pulmonary system, you can get pleural effusion within the lung tissue. And that needs medication to get rid of it. So typically we'll give you like a diuretic to help get rid of this fluid. But both of them can collapse a lung and compromise it. Okay, so here you're seeing on the patient's right, there is a silhouette of the heart, and here is the actual fluid, and the fluid builds up very, very quickly. Typically it collapses the lung. Now, air in the lung is called pneumothorax. I showed you this earlier. It can be happened from a bullet wound, from a knife wound, from atmospheric air getting in there. It could be due to smoking. It could be due to other underlying pulmonary disease like emphysema. Anyhow, when air gets in here, this is from a bullet wound. You can see the chest wound, the atmospheric air is entering the lung. It's it's between the visceral and the parietal membrane. It's collapsing the lung. And if you notice, it's pushing the heart towards the left and collapsing the lung on the left because of the heart. The air between this lung is called the pneumothorax. When it does this and it compromises the opposite lung, that is called a tension pneumothorax. That's a problem because now both lungs are being compromised and you are not going to be able to breathe worth a crap. And that's what's happening here. You have a pneumothorax. Air in its X-ray is black. So no fluid. It's just black air. This is the lung tissue. That's all the lung tissue you have left, and it's being pushed towards the heart. If you notice, the heart is being pushed towards the left, and the lung on the left is being pushed towards the actual pleural cavity. So you got a big problem here. So you get pain, shortness of breath, that's the abbreviation SOB, and that can lead to cardiorespiratory collapse because the heart is being pushed and not able to squeeze and contract, and that's squeezing the left lung. So you can die real quick if this isn't fixed. And the way we fix this is you put a tube or a needle into here and suck the air out to allow this lung to expand. Okay, so that's one way to do that. All right, guys, that's the end. Please review these. If you have any questions, email me. Um, Contact me in any way. Email is the best way. And during lab, we'll be going over all of this. So I'm going to post these on Blackboard, and you'll be good in shape.